No company or factory operate here to provide job for people, and most of the NGOs have also left the city.
We lack schools because we only have one structure and it can't accommodate all our children.
They started learning some of the questions that we will ask them at triage when they come, so the patients were lying. There was not truthfulness, and that created fear. And also, even amongst ourselves, the animosity the disease was creating, everybody wanted to leave. Some of us wanted to leave, but we couldn't just leave our profession and go away. Personally, Ebola affected me and my family. Whenever I'm off duty, when I get home, I make sure I don't go close to my immediate family. I had a few nurses who came and told me my husband says I should not walk. If I walk, I will not be able to go to that house again.
Well, there is no way we can have the money. The amount, if you are to eat at least 5 cup rice in your family, you reduce it to 4 cups because of the prices increasing at that time, because vehicles are not running, and to travel from here to Freetown it costs 100,000 rands.
With those challenges, but we still say thanks to God for His mercy. But we don't mind. We know that one day our Lord will see us through. But we hope and pray that they will remember us one day. I just have to cope. I have nothing else to do. I pray that things will change.
Many people in our community are sick, and we don't know why.
يا رب طول عمرك.
Over the winter, we ask for wood and aid, but we don't always get it. The tent would fall over our heads and no one would help. Organizations would come here and help those who don't need it. One winter, the tent fell over my children's heads and my husband can't work. We called an aid organization asking for help, and they sent 2 foreigners who took pictures.
Anyone who has to handle something beyond their capacity would suffer from mental health problems. It is exhausting. As long as people are pressured and have to work 2 and 3 jobs to live, they will not feel better. The first resort in this country is religion. People have a high level of faith. Because there are so many different religions, it has proven to be a good coping strategy. They might go to a sheikh or a priest. Then there is the social circle if it is accepting of the issue we are facing, which is not always the case.
The camp is never the same, albeit with roughly the same area. New faces, new dialects, narrower alleys, newly constructed and ever-expanding thresholds and doorsteps, intertwined clothing lines and electrical cables, well-shielded balconies, little oxygen and impenetrable silences are all amassed in this space. The shibboleth has never been clearer and more poignant than it is now. Refugees ask other refugees, "Who are we to come to you and who are you to come to us?" Nobody answers. Palestinians, Syrians, Iraqi Kurds share the camp. The same different camp, the camp of a camp. They have all come to re-originate the beginning with their own hands and feet. Now in the camp there are more mosques, more houses of God, while people continue to come and go, like the calls to prayer emanating at slightly varied times from all these mosques, supplementing interrupting, transmuting and augmenting the voice and the noise simultaneously. Badawi is a can that lives and dies in our side. It is destined to remain, not necessarily as itself, so long as time continues to be killed in its corners.
Karen, for sharing that. I'm going to come to Aya in just a minute, but just a couple of things about that brief video. Quite deliberately, we tried, as well as sharing the voices of people in those circumstances, we tried to share the sounds. That was the sounds, that the atmosphere of Badawi camp in the north of Lebanon. And alongside some of the sounds, some of the voices coming out of that in terms of poetry. So Yusuf Kazmia, the poet that was reading his poem there, actually has just recently had his book of poetry published, and it has received a number of awards. I think it's the poetry book of the first quarter for the Book Association. So as a research team, I think we're recognizing there's different ways of representing the experience of people in challenging times. So I hope that's been helpful for some of you to get a feel for the settings that we're talking about. Aya, I'm going to come to you in terms of Jawo is not with us yet, so I might go back to the earlier part in Sierra Leone with him a little later. But if we focus on the second half of that video in Lebanon, the big shock, the big pressure is around the influx of refugees from Syria. Now, I can actually see Jawo has just joined us. So Jawo, I'll come to you in a minute. That's great to have you with us. But I'll stick with you, Aya, now. Tell us about that and how that has impacted the country. Let's talk about mental health in a minute, if you like. But before that, in terms of thinking the pressure on the whole country, what's been the impact of that refugee influx from Syria?
Well, in terms of the pressure on the country, definitely the impact or the influx of the Syrian refugees has affected the whole country on different levels. And mainly we have seen that through the discussions that we conducted through the GMBs, where we were having like some kind of tension between the host community and the Syrian refugees because of the competition on the employment, on the, for example, I would like to add now, given the deterioration of the economy in Lebanon, we're having these challenges in buying the goods and basic needs and the subsidies and reduced prices of items. So definitely the influx has affected the country. Also, I can add that on the health system itself. So we have realized that at the primary healthcare centers, mainly in the Bekaa, we have like most of the beneficiaries are from the Syrian refugees and not from the Lebanese population, because they are being covered by the UNHCR. So definitely it has affected the country on different levels.
So you sort of began to do it there, but I want to link it specifically to mental health. And often I'm just struck that you were talking about physical living conditions and not having a job. And those very practical concerns. We're often thinking of the trauma or particular experiences of loss. In your discussion with refugee populations, how did those two things fit together? Was one more important than the other, or is it not a sensible question? Are they wrapped up together in terms of the mental health state of the refugee population?
No, definitely. Of all of our participants who were part of the studies, they mentioned that they have suffered from the traumas due to the war that they have lived in Syria, and due to losing a family member or losing their whole houses or even their businesses. So they had their displacement to Lebanon definitely has changed their whole life and affected their mental well-being. In addition to that, that, there's a whole challenge in like trying to find other living resources in a new country, which is causing also a stress with the host community and leading to more stressors for both communities, either the Syrian refugees and the Lebanese population. And definitely both of them are suffering from these kind of stressors, leading to some sort of mental health disorders or issues. So I can look at it as a cycle where all of these factors are linked together.
They fit together. One thing, if I understand correctly, that came out of your work, the way you were doing it in terms of discussing with groups, you were keeping men and women separate in terms of discussions. You would talk to people from the community. Tell us partly about why you separated them, but also what different stories you heard from men or from women, how their experience was expressed differently.
First of all, definitely we separated them by gender due to the cultural aspect, and for both, for each group, like to have that some sense of safety and relief to talk about the different topics that might affect their mental well-being. And so it was like a sense of like feeling safety and relief when talking about that topic. Another thing we have seen definitely that women talked about gender violence, gender-based violence, or about the aggressiveness or the man role at the house, or the patriarchal system that they might suffer from, which maybe in some cases might not be said if they were mixed together. However, men, like their common, they were just mentioning the common talks, and we did not, I can't remember like a topic that was really odd. However, women were mentioning gender-based violence, and even I can remember that there was a talk about sexual violence in these senses, so that might not come up in case they were mixed.
Okay, thank you, Ian. I think that's a theme we might pursue about the different way that men and women experience and process experiences related to their mental health. One last question, Aya, before I go on and I'll speak to Jawo, linking to the earlier part of the film, is an important part of your work was not just to identify those needs, it was to help the Lebanese mental health services and NGOs working with them to provide better services. And I know on Tuesday, as part of the festival, there was a meeting or a briefing, or you've had briefings this week with the teams. I wondered if you could just identify one or two things that you think are coming out as recommendations from the work in terms of making sure that mental health services, in whatever way we understand the services to be better, more effective in what's obviously a very demanding situation with the number of people involved and the scarcity of resources. So what's the implications of your work?
To be honest, now we're facing like major challenges in the country, and I think that mental health is being a little bit on the side, but at the same time we're like seeing that there are lots of initiatives and awareness campaign on raising awareness on mental well-being, and to like be aware of the mental well-being of each person. And there's like so many platforms and online initiatives that are being done for online consultation. This is what I'm basically now aware of, but practically we're not that much active in providing mental health care given the whole deteriorating situation in the country. Yeah.
No, so I recognize, and I think again that will be a fact we might pick up in the discussion, that in a crisis it's sometimes hard to assert mental health to be a priority, even though it feels. I also am interested by that idea of online consultation, because I think that sense of other forms of resource to support people is becoming quite popular, and recognizing that can get over some of the barriers, particularly when there's a shortage of trained staff. But anyway, thank you, Aya, so much for that. Jawo, lovely to have you with us. I'm delighted that you're on mute at the moment, Jawo, but I don't know if someone's going to unmute you, or you can unmute yourself.
I've unmuted myself.
Oh, lovely to hear you, Jawo. So sorry that you just missed us at the outset. Sheila and I have had a brief opportunity, as well as myself, to introduce ourselves. Just for 20 seconds, could you just introduce, for those that are in the meeting, just in the call, just to introduce yourself, and then I'll ask you a couple of questions.
Actually, I'm Abdullah Jawo Bah. I'm a PhD student at IGHD on global mental health, but working specifically on perinatal depression. Lecturer at College of Medicine, pharmacy, like my background, did my master's in pharmacology in China, but currently doing my global health, mental health with IGHD.
It's great to have you with us, Jawo, and I know you're very much involved in service delivery and field work at the moment. We showed the video that we used last year just to set the scene of life and challenges in both Lebanon and in Sierra Leone. We shot that before, most of it before COVID. It was just about the beginning of COVID. But one of the things we flagged was the series of challenges in the country dating back to the Civil War and then the Ebola outbreak. And I want to talk about more contemporary things, but I wanted to ask a question before we get into mental health issues that are currently reflected. With those big challenges to the whole country, which obviously a civil war is, and then Ebola was a huge loss of life, not only within communities, but within the health service. For people with enduring sort of long-term mental health problems, what sorts of facilities have been in Sierra Leone and what services continue? So I'm thinking about people perhaps with symptoms of schizophrenia or other psychosis, sort of quite serious long-term enduring mental health issues, just to give us a feel what sort of services have been available for that group.
Well, unfortunately, at the end of even the rebel war, there was no much provision in terms of handling the mental health of people post the war. And as for now, in terms of mental health services, Sierra Leone still continue to have this institutionalization process. We have one psychiatric hospital at the urban within Freetown, and at district level, we just have like one mental health nurse per district. One district can be like 500,000 population. And these mental health nurses, we are trained based on the MHGAP program, which was contextualized in Sierra Leone, part of the task sharing and task shifting program. So it's like those that are severely ill are the ones that are brought to the psychiatric hospital. Initially, they were trained, but about 2 years ago, the training has been discontinued. For now, it is purely like institutionalization. So as a result of that, there is this inequity. And also most of the resources, though there is no like budget line for mental health, the meager resources that is available is being poured basically at the psychiatric hospital.
So Jack, you said it quite quickly, but it's quite shocking or profound in a way about chaining. So you're saying clearly now that's not part of the policy, but historically and until fairly recently, for someone with a severe mental illness, it would still be at a community level practice that they would be restrained effectively. Is that right? That's what you're saying, just clarifying.
Yeah. The discontinuation was like advocated for by the Minister of Health about a year ago. And that is just at the psychiatric hospital, but at community level, it is still ongoing. And it will even surprise you to know that though we have not published, but part of the data we collected some time ago at community level is like over 90% of people like try to access the traditional medicine pathway or religious institutions. So like the hospital is always the last resort when they have run out of money and when cases have become very severe. But up till now at community level, they are being trained and a good number of them are beaten up because like some of the traditional healers, they have this impression that they can beat the demon out of them. And I visited even like one traditional healer at Devolo just outside in the outskirts of Freetown, who has like different forms of chains. You know, when the patient is very, very violent, they use much bigger chains. So as the patient like gets less violent over time, the patient is transferred to smaller chains.
So Joe, I want to talk about more issues of mental health related to the stresses of living and some of your own work around perinatal mental health for women in childbirth. But we'll come back in discussion later to that, and I'll be interested in Sheila's reflection, partly about working in Malawi, but about supporting the community, effective community care, basically for people with severe and enduring mental illness, so that if we're having a conversation about mental ill health, it's right that we acknowledge that there are people with very severe debilitating disorders, and you're tracking there, Jawo, that things are in transition, and centrally services are much better, but at a community level, there are some still big challenges. So let's come to that later in the conversation. Tell us a little bit, Jawo, about your work with perinatal mental health. Tell us a little bit about what you see as the issues around mental health for women in Sierra Leone, particularly around the time of childbirth.
So currently, what the data is like telling us is like we've been focused on the idiom of distress and explanatory models, this emic and ethic. So it's like what is coming out of the whole thing is like a good number of these women like economic hardship and also problems with the relationship aspect with their partners are the key problems that are the key etiologies of the problems they are going through. And when we did like a free listing, we realized that the women, asking them the problem that women are suffering from, they will list poverty and other things, and they also come to aspect that has to do with thought, feeling, and behavior. So it's like women are fully depressed, but they themselves are not conscious of it, that it is something they can seek help for. They always try to align it with social suffering, basically. And when we also look at health...
Just a second, because you've said some important things there, I just want to clarify again for those listening in. So you mentioned about emic and etic. So I think what we're saying from that is that in understanding the experience of those women, we want to use our scientific technical knowledge where it's relevant in terms of coming up with categories, but we also want to reflect the local experience of those women. So I think is that a reasonable translation of those two terms? So we're trying to understand it scientifically, objectively, but we're also trying to understand it subjectively from the culture. And I think the other thing you said, which I think you caught Aya talking about this, that two of the biggest factors you were saying were sort of social conditions, living conditions, and also relations with a partner, you know, and that interpersonal dimension, including potential interpartner violence. So I think that it's fascinating that even then, just spontaneously from Aya and then from you, Jawo, that we're seeing that as a fairly key dynamic, particularly in situations of hardship, recognizing that those bring economic problems, and they also bring stresses within relationships and within households. Jawo, we're gonna go to Sheila probably before the next video, but I want to ask you one final question again before we do that, and it relates a little bit similar to what I was asking Aya, the sort of so what question. You're studying what people do when they don't feel well, how they understand it, but I presume you want to make services better, and I think you're exploring some ways that rather than relying upon skilled psychiatrists or psychiatric nurses that are in real short supply, you can use other resources or other people within the communities to support people with mental ill health challenges. Do you want to tell us a little bit more about that, the sorts of interventions that you think realistically, practically, usefully are going to be viable in Sierra Leone?
Yeah, so realistically, based on the data we have collected, we looked at coping mechanism and health-seeking behaviors. What are the local resources these women have been accessing? And overwhelmingly, all of them are saying like they have been meeting friends, they have been talking to their neighbors, their mothers-in-laws. So it's like they have been talking to them, trying to mingle with them, and that has been helping them a lot. And even we also had a caveat: if all resources are available, what would they suggest would be the best line of action? And the laywomen, overwhelmingly from the community, just 1% of them suggested medical, but 99% we are talking about, well, trying to empower these women, helping them with business so that they can able to focus on it and distract themselves from the stress they are into. And also a good number of them, what we are saying, like to help them so that they can have people to talk to mingle, and that will help them to get better. And one of the things that is also interesting to note is the fact that these women know very well that the problems they are going through can also affect their babies, because some of them, we are saying as a result of these stresses, they decide not to suckle their babies, not to take them for immunization. And yeah, so, but it's like the counseling pathway is what they have been accessing, and that is also what they are suggesting if resources are available.
Okay, we might come back to that later, Joey, talk about a counselling pathway, but you're saying that that's using people in the community to provide advice, counsel, support, and I think you said that medicine might be part of the picture, but is not the picture that's emphasised. It's about identifying ways to help solve some practical problems that people are experiencing. So thank you so much, Joe, for that. As I say, because we ran a little bit while we were waiting for Joe, I wanted to probably go straight to Sheila. And the question I'm not going to ask you straight away, it is the one about parallels and differences, but it makes sense just to ask you about Scotland first, because I'm sure you're dying to comment on things that Aya and Joe were sharing. But perhaps just to start, well, like I was asking Aya about sort of, and Aya was saying at the moment, mental health, there's so much other things going on, it's not got a big focus. What do you see as the case in Scotland, and particularly in the NHS in Scotland, Sheila? Do you think mental health has a big sensitivity to it now, or it's at the margins? And over your career, how would you see that the agenda of mental health has sort of changed and evolved?
Oh, I'll unmute myself. Yes, I think this has struck me that how important the awareness raising is, because in some ways I feel that goes back to the early days of my career, where in the UK we had a lot of big institutions with people with mental health problems and mental disorders were mainly in institutions. And so during the course of my career, I have seen people move from those settings into the community. And sometimes I kind of reflect, you know, in the work that I've done in Malawi, that, well, actually, you know, and it's in common with many other countries, you're not actually going to have to go through that process of, you know, incarcerating people in hospitals and then having them leave. You can, you know, jump to the community care directly, which I think is a very positive thing. But the whole getting mental health up the agenda, both within the community, anti-stigma campaigns, anti-discrimination campaigns, awareness raising of mental health as being like as important as other non-communicable diseases. I think it's a process. It takes a long time, but it begins with this awareness raising. So and gradually it gets onto the agenda permanently. Yeah.
So I think you were the first person actually to mention that word stigma, and it was Aya could have mentioned it, I think, and Jawo could have mentioned it, because I think it has come up in the work in both countries that there's a reluctance to talk about mental health issues, which there isn't about physical conditions and so on. So you think, again, in a country within the UK as Scotland, at one level you'd think it's now easy to talk about, everyone's talking about mental health, but do you still think there's some stigma there about people owning that, or just tell us about that process?
Yes, I mean, I think and in common perhaps, you know, with many other countries, there are groups where it's still really difficult. And, you know, men, for instance, that I think that is still an issue that we have in Scotland, whereas men are more willing and able to talk about their feelings and mental health in general. It's still a group that are still find it maybe more stigmatizing than women do.
Yeah. So Sheila, before I ask, well, the next question really is around what are the things that you've been involved in Scotland over the recent years that you think are good intervention models? Things, I'm not saying that we're going to replicate them in Lebanon and Sierra Leone, but the things that you think you'd want to put in the pot as this has been a good strategy, or this has been an important way of developing services. What would you see as good ways of having mental health burden that you've seen from your time in Scotland?
So I think the move towards multidisciplinary community mental health teams has been very positive. And that is, if you like, being rolled out further and further with in this current Scottish government policy for currently is about trying to put mental health workers, so from a variety of backgrounds, but with skills and experience in mental health, trying to put a lot more of those in settings where it may be the first point of contact, for instance, in accident and emergency departments, in prisons, in police custody situations where people are vulnerable and there's a high level of mental distress and mental ill health. So they're trying to get not necessarily that that person would deliver all the care that might be needed, but to ensure that people who are vulnerable are given support and assistance at an early stage and directed and signposted to the right sorts of services.
And Sheila, can I just in that model, just so I understand what we're meaning by multidisciplinary, if I have some issues and I meet that person, they've got a little bit of nursing knowledge, a bit of medical knowledge, that they've got some social work knowledge as well. Is that the idea, that they've got some exposure to a variety of different sort of disciplines and knowledges that might be relevant?
Well, they can come from a background of different disciplines, and not necessarily a professional one, but some people who are just you know, experienced through what we call third sector organizations. So not necessarily working with strictly professional role like nurse or doctor, but actually being a mental health worker through experience, if you like. So they have some knowledge and experience, and also a good understanding of how the mental health system works in our country, because it is quite complex. On the one hand, having a multidisciplinary, multi-agency community team and community services is really good. It becomes more and more, or it can become more and more complex and difficult to navigate your way through. So I think they're trying to, Scottish government policy at the moment, trying to ensure that mental health is considered in every point of contact that people have with health and social services, but particularly where they are likely to be their most vulnerable, either in an emergency setting or a custodial setting, for instance. So
Sheila, I'm interested by that word navigation. So in moving us on, and then this is probably my final question, then we Karen, if we've got any Q&A, I'll come for any other questions that we might have with you know, from those attending. But I'm interested, Sheila, in sort of, as you've listened to Aya and Jawo, sort of things that you see as quite familiar, sort of similarities or resonances, or things that you think quite different. But by using that word navigation, it just struck me that I think we've shared with you some of the papers that Aya and Jawo have done about all the routes of when you're sick, where you go to and why you'd go here and there. So it seems that that navigation problem isn't exclusive to Lebanon, and the barriers and the problems of getting through to someone is not just about Lebanon. Yeah. You've got that in Scotland as well.
Yes, yes. I mean, I think it's, I think there are, although it's strange to say, there are many more maybe similarities in what we grapple with, and what are the, you know, the most challenging things, like people's economic status, because you know, in Scotland we have actually a huge inequality in terms of, like, you know, health outcomes, both in physical health and mental health, in a very, very small country with between, you know, small geographical area, real differences. And people with mental illness are, you know, even more disadvantaged in terms of life expectancy and so on, with these contrasts. So these inequalities and getting to the right people, or right people come to us, is a very familiar, you know, situation.
I just come to Aya on I'll come back to you, Sheila, but that idea of inequalities, the barriers of people that had needs but not being able to identify the way that they could respond to those, or who the service providers were, that was resonant in your work also, is that right?
Can you repeat again, Alastair?
This idea of navigation, basically, I'm saying it seemed that in your work, people finding their way to a service was a problem, and there were quite a lot of barriers to that. Perhaps just tell us about some of the barriers that you identified in your work.
Yeah, so definitely there are so many barriers, and I might say that a common barrier, first of all, definitely social stigma is one big factor that is shaping the health-seeking behaviors of all people in Lebanon in both settings. We have in the least fragile and most fragile, and also their awareness to their mental well-being and their willingness to go and seek help from a professional source. The costing of the treatment is one of the major barriers because it's not available unless you go to private clinics, which costs a lot for a patient to seek care. And also the trust and the quality of the service and the ability of the provider to give the appropriate care, and the fear from the treatments and its side effects, where all of these were main factors that were mentioned by the community members and that were shaping their behaviors to seek care from a professional source.
Thanks. You mentioned that word trust. Can I come back to you, Sheila? Because in our work, one of the reasons we're looking at mental health and looking at non-communicable disease is the challenge of what we would term continuity of care, really, about these are things that it's not like being sick with a fever and going to see someone for a quick consultation, having that sorted out. That these are issues that will go on for months and for years, and that building up confidence and trust in providers seems really important, but really difficult in a fragile setting. From something I know of your work, tell me about trust in provision in Scotland. I mean, is that for people who are most vulnerable to be able to have confidence in the services and find their way to them and develop relationships of trust? Is that a big dynamic given the quality of service provision here also?
Probably more for you know, smaller populations, well, such as asylum seeker and refugee population, and others who are from, you know, a minority cultural background, then certainly I think they would find it more difficult to establish trust, and there are still significant cultural differences in how mental health problems are viewed within those smaller populations, because we go to a very medical model. Well, often that people can feel, even you know, people who were born in Scotland, brought up in Scotland, maybe nowadays are perhaps mistrustful in some respects sometimes of a medical model, of a drug treatment or whatever. So for different reasons, people may have some issues of trust, but generally I think there is a good primary care, very comprehensive good primary care set up in Scotland. And in fact, family practitioners, general practitioners, they do see the majority of people with mental distress and mental illness before they come to other services. And
just on that, Sheila, just recognise that from Ager's work, that the most promising stuff is building on mental health provision to existing primary care.
Yes, I saw that. Yes, exactly. Yes.
Do it. Sheila, last question I think from me for you, that I sort of interrupted you in your flow about similarities and differences. So you were talking about, suppose, anything in Jawo's description of things in Sierra Leone that either resonated with Scotland or with your work in Malawi in terms of some of the challenges and issues there?
Yes, well, I was pleased to hear that there's a good rollout for the MHGAP training program.
Do you want to tell us what there might be some people on the meeting who don't know what MHGAP is. Just tell us briefly what that is.
So WHO training program aimed at training program in mental health aimed at non-specialist workers, health workers primarily, and using a train the trainers model. So as Raz pointed out, that the actual trained and qualified mental health resource in the country is very, very small. But it seems to be a good model to equip if it's properly delivered with supervision afterwards and so on, to train people who are non-specialists within healthcare settings to deliver mental health care as well. Now, was there another?
I'll come back to you in a second, Sheila. Don't worry. While you find. So I'm just checking.
So much to think about.
that indeed. So I see a comment from Vladimir who has to go, but yeah, appreciating the comparative discussions that we've had. Karen, can I just check? Is there anything in Q&A that I can't see that anyone particularly wanted to put to our guests? So I'm going to move towards final comments and wrapping up in the next couple of minutes, and then we've got another video to share. But is there anything? Oh, we've got a question. Is that right?
There's a couple.
Oh yeah,
now.
Go on, Karen. Do you want to? You put the question.
Sure. Yes, sure. So we've got a couple coming in. They're coming in via chat, but I would encourage you to use the Q&A anyway. So we have one from Leila for Jawo. Could you say more about what type of support women were going to, family or friends? You know, why were they accessing those different sources?
There you go.
Yeah, go on, you go.
Yeah, so actually, like, talking to these women, it's like they identify their social suffering as social issues, because, for example, you'll see a woman getting pregnant, the man deny the pregnancy, and this woman basically, sometimes the family, because of shame, they ask the woman to go out of the house. And you have like some community members now that will come, provide shelter, feeding, and support for that woman. So most of their problems are social sufferings, and they just believe that some of these social suffering can only be handled by family, friends, and community. Because there are instances where also community would put some amount of money together and help buy clothing for the baby, provide food and soap for the mother. So most of these things like resonate around like some of these social sufferings like food, lack of shelter, and also some amenities that women do need during their early, as newborn mothers.
Mm-hmm.
And just before we go on, Karen, so Joe, I think it's really interesting, and your use of the word social suffering, I want to link it to something Sheila was saying. It's that there may be symptoms and mental health issues related to that, but the context of it is a social struggle, basically, and there are social resources that can help resolve that. So sometimes we're fighting against medicalizing things, but in that instance, that it seems like the idiom of distress. There's an understanding this is a social situation which is demanding and difficult, and there are social resources may help you resolve it and sort it. Yeah. Karen, we're going to bring Zena's question, yeah?
Actually, I'm going to go to a different one, if that's okay, because Zena's a little bit more restrictive in that sense. So we have Bryony who's commenting on the fact that in the UK, for example, you have limited time with the GP, so 5 to 10 minutes, for example, to detail your problems. So she's just wondering, obviously there's initiatives underway to expand that time, but how do people access the mental health support, care, therapeutic interventions in Lebanon and Sierra Leone? Is that very similar, or can you just provide a little bit more background detail on how people, what is their point of contact? Do they need referrals? What do those processes look like?
So if I just quickly interpret that, if I'm right, so like Sheila was saying, which is the case in the UK, in Scotland, quite often it's through the GP. That's the sort of the gateway through. What are the effective gateways in Sierra Leone and Lebanon?
Yes, essentially.
Is that a reasonable understanding, Karen, do you think? And you were saying that things have become more difficult, but yes, how do people access resources, services at the moment? You said there are lots of barriers, but what are the things that they're trying to get access to that would be potentially relevant? How would they do that?
When it comes to mental health services, I think that there's a certain social class that will be able to access mental health services, and mainly they're going to go directly to a psychologist and clinical psychologist to private clinics. This is what I would mention. For the other people, I think that social media is playing a role in like raising awareness for people who have the accessibility to like access all the social media platform on how to determine their mental well-being if they are suffering from certain anxiety symptoms or depressive symptoms. Other than that, I don't think at the moment there are other ways to accessing mental health services. It's being really strictly to a certain target people.
Okay, thanks. So Jawo, what's the emerging model in Sierra Leone for people themselves to access resources and to seek help?
In Sierra Leone, the stigma is very, very high. And as a result of that, when people get sick mentally, the family, first of all, come together and try to see how, as best as possible, to suppress the whole thing and keep it within the family structure. They can contact like a neighbor and ask for their suggestion, and they will then identify like a traditional healer, an imam, or a pastor. So most of the time, the way they conceptualize it, they look at it as like a spiritual thing rather than a biomedical thing. So it is even surprising for you to note that they can even take some patient from the city of Freetown, just next door to the mental health hospital, to the provinces, like hundreds of miles away, to like check a particular traditional medicine practitioner that has been recommended, you know, based on maybe like his past track record, have treated someone some time ago and get cured. So it's like they exhaust all these pathways, like going to traditional healers, imams, and all these other informal pathways. So it's like the hospital setting is always the last port of call when they run out of money and when the patient basically is severely ill. And sometimes they can even release them in the community and never even check to the hospital, because as far as they are concerned, it has to do with their social wall in terms of like, you know, related to like societal, like God and spiritual theologies rather than biomedical.
Okay, thanks, Joe. I'm going to go to Ager for another quick word, and then we're going to wrap up in the next 5 minutes. I'm going to end with I'll end actually with a short video. I'll explain a little bit about that in a moment. So I'll come to you, Ager, and then Sheila, I'll give you the last word. And I suppose it's sort of you can say what you like really, but my reflection is, when you're in a conversation like this, so you're practicing in a very wealthy context, essentially, with quite well-developed resources, but you have experience, as you say, working in Malawi and elsewhere. It's about that reflection about commonality or difference. I mean, do you feel that there is the potential for a global community, some global best practice here? Or do you feel we're very, you know, we've just got to do different things in different settings? That's probably what I'm going to ask you, but I've given you warning of that question. And let me just go to Ager, because I think you had your hand up. You were just going to share something about the access. Is that right, Ager? Well, I've lost you now, Ager, sorry. Ager's frozen on my screen, so I'm sorry. I was going to come to you, Ager, and I will do again in just a second if it looks like we've lost you. So thank you so much, Ager, for your input. So Sheila, we actually had someone commenting that they valued this sort of triangulation, 3 countries, 3 reflections. But is it genuine? I mean, do you think there's some way we can share best practice, or are we just in very, very different contexts and have to develop our own solutions?
Well, yes, I actually think that there are far more commonalities and opportunities for learning than maybe some people, even some of my colleagues might think. And you know, I was hearing about what Jawo was saying earlier on, and of course, the whole issue about what is stress and what is illness, and I really liked your pointing out that these can be whatever we call it or however we diagnose it, it is still distress of some sort. But I think that is what we're at risk of here in Scotland, is exactly medicalising all distress. So because there is a demand for help and assistance and support with mental health, and that's a good thing, I think it's about working out how we do it. And I think of the example of the friendship bench, which I don't know how many people are familiar with, but this was a really similar to what Jawo was talking about in Sierra Leone, which started in Zimbabwe with the grandmothers with some, training and support, helping in their community. So a little bit, not just a totally informal provision of mental health support, but something a little bit more formal and perhaps a little bit, more independent, which can be helpful for some people at times, but very much not medicalizing what was going on. For instance, they would help young mothers. That was one of the groups that would come to them for a kind of sort of a CBT problem-solving chat, which they report very good positive results from that kind. And I think we could learn, a lot from trying to do things like that and not get too caught up with formalizing everything and making it very diagnostically driven.
Yeah, thanks ever so much, Sheila. I can see another question actually just as we're coming from Patrick Wilson, and I think it's a really important reflection, which I'm just going to come to Jawo with, which is that if we look at the recent history in Sierra Leone, to be honest, we've got some strong policies in place, haven't we? We've got the strategic plans. There's lots of elements that are in place, but not so much on the ground. So, I mean, is that a fair reflection? I think that's a very quick summary of a really important posting that Patrick's made about translating something that's a policy directive and a decision with donor support in Freetown to actually translating that into practice in a very common way, scale up across the country, is a very big difference. And that's one of the challenges of working in fragile environments is to take things in paper where there's consensus at a senior level, but actually translating in that to delivery. Is that I just wanted to give you a chance to reflect on that, Jawo, as Patrick has shared it. So I know you're interested sorry, and just to say, because I know you're also interested in the change of the law. I think Sheila mentioned, sort of legal frameworks and things within Scotland. That is still pending, I think, within Sierra Leone, the change of the legal status and understanding of mental ill health.
Well, the problem with Sierra Leone is like there's lack of political will, and also the issue of like competing priorities, focusing more on infectious diseases and other mother-to-child ailments and neglecting mental health issues. So it's like even the previous mental health policy and strategic plan was very beautifully written with lots of like intersectoral approaches in there, but it was never translated actually. And now we had an other updated version, but up till now, even like the launching of that policy and strategic plan, they postponed it like about 3 times before they finally did it as a result of because of lack of finance. So up till now, it's like, and for now, it's like the priority are more focused towards COVID, and even the National Coordinator for Mental Health, Anti-Kadi, is now like more focusing on COVID-related mental health and not the actual mental health policy and strategic plan that has already been outlined. So political will basically has always been a problem.
So thanks, Jawo. We're going to have to wrap things up. We're just after 3 now. Just 2 or 3 pointers. I'm really pleased and proud that Jawo and Aya and others are very much involved in work that is close to implementation and service development. So it's not quite a friendship bench, but Jawo, your work in terms of support for women, that very practical, concrete service development approach is a way to address some of these issues. And that's why it's been great to have Sheila in sharing the experience of working at a frontline level in terms of psychiatric mental health service delivery. That's the way that we build services, as well as at the policy level. That's important, but we need to have really practical models that are working. So I'm really thankful that we've had you, Jawo and Aya, on the call, sharing experience of seeking to drive that development forward. Thank you so much, Sheila, for your time and for your insights. Great to have you on board in this discussion and respecting your work very much here in Edinburgh, in Scotland, but also your willingness to engage with broader global debates around MHGAP and around humanitarian situations and Malawi. That's a close. This is the penultimate activity of the Global Health Festival this week. Returning to the theme of non-communicable disease, we have the Mexican film El Susto, which is talking about the shock, addressing the huge challenge of ill health due to sugary drinks in Central America, just as an example from Central America, looking at advocacy and political process to challenge that. We're delighted to have the director of the film and also activists from Central America in a discussion tonight at 6:30. The film is available all afternoon to see, and you actually can also see the film tomorrow. But after tomorrow, you can't. So I really encourage you. It's 1 hour, 50 minutes long. It's a really vivid depiction of good public health action, challenging inequality and looking at ways of ensuring effective policy development to support population health. So I encourage you to either join us at 6:30 GMT for the discussion with the director, or otherwise this afternoon or tomorrow to watch the film itself. Thank you for your engagement in this discussion. I strongly encourage you to look at the video gallery, to look at the digital stories, to look at other materials, either today or tomorrow, but also it'll be available next week and beyond. And we're just going to close with an animation. We're going to have some great animations from Lebanon that have been used to develop some of the themes that from the fieldwork there. But just got one to share with you now, which is around the issue of physical exercise and engagement as a way of supporting well-being. And it features an animation regarding refugee youth in Lebanon. So we'll close with that. Thank you, Karen and Julia and Mari, for your work in the background. And thanks everyone for your engagement.
Thank you very much. Pleasure.
أمرار بحس حالي زعلان وزهقان، ما بحس حالي متحمس أعمل أي شيء، بس فكر بالمستقبل بحس بالخوف وبعطل الهم. كل اللي بعمله إني قاعد بالبيت. بدي أغير هيدا الشعور بس ما بعرف كيف.
في كتير أشياء بتصير نحن ما فينا نسيطر عليها، وهذا شي عادي. أتذكر في أشياء تانية فينا نسيطر عليها.
شو هالأشياء؟
إنه نضل بنشاط وحركة، بس كون نشيطة بحس حالي قوية، عندي طاقة أكتر لأعمل أشياء أكتر كل يوم، بحس إني مبسوطة أكتر. بس كون زعلانة أو مالي خلق على أي شي بحب كون نشيطة، هذا الشي بيخليني أكتر مبسوطة ومرتاحة مع حالي. أنا بحس بصحة أفضل بس أعمل تمارين، عم بعمل جسمي أقوى كرمال أقدر حارب أكثر الأمراض.
بس أنا ما عندي الطاقة لأتحرك، ما بحس حالي فيني أعمل رياضة.
أمرار بداية التمارين الرياضية هو شي صعب، ولكن مجرد أنك تبلش رح تحس حالك أفضل. كل ما كنت نشيط كل ما كان عندك طاقة أكتر. التمارين الرياضية هي لكل شخص فينا، إن كان صبي أو بنت، كبير أو صغير. النشاطات الجسدية بتساعد على تخفيف الضغوطات بجسمك، هذا بيعملك مبسوط أكتر رياحة وصحة أفضل. كل شخص بالعالم في يعمل تمارين، ما بيهم مين بيكون أو وين بيعيش، لازم بس تلاقي التمرين أو النشاط اللي بيخليك مبسوط።
ቤቴ ሆኜ የአካል ብቃት እንቅስቃሴ ማድረግ እወዳለሁ። በየቀኑ ተነስቼ ፑሽ-አፕ፣ ሲት-አፕ እና ቁጭ ብድግ እሰራለሁ። የመጀመሪያ ጊዜ ፑሽ-አፕ እንቅስቃሴ ለመስራት ስሞክር ለ5 ጊዜ ብቻ ነበር። ከ2 ሳምንታት በኋላ 10 ፑሽ-አፕ መስራት ቻልኩ። አሁን በየቀኑ 20 ፑሽ-አፕ መስራት ችያለሁ። ብዙ የአካል ብቃት እንቅስቃሴ በሰራው ቁጥር ጠንካራ የሆንኩ ነው።
بحب أمشي وأتنشط، عندي كبيرة بالعمر، عندي تسهيل نجاة، ظهري بيوجعني. لما نشط جسمي عقلي وجسمي بيرتاحوا، أحلى من القعدة طول النهار.
أنا بحمل أشياء ثقيلة بسبب شغلي، وهذا الشيء بيعطيني لياقة جسدية وبيخليني أقوى كمان. وهي القوة بتخليني أتسلق أقوى ولوقت أطول كمان.
الشباب والصبايا لازم يمارسوا الرياضة أقل شي 150 دقيقة بالأسبوع، ونحن كأولاد لازم نلعب أقل شي 60 دقيقة كل يوم. في كتير نشاطات فينا نعملها.
هيدا شي كتير حلو، بس بلكي أذت حالي.
بس تجرب تمرين، ما تنسى تبلش بشكل بطيء كرمال تتأكد إنك عم تعمل حركات مظبوطين. رفقاتك فيهم يساعدوك، ما لازم تكون بطريقة بتأذيك. أمرار التمارين بتكون بدها تحدي أو صعب شوي، هذا بيساعد جسمك وبيعمل عقلك أقوى.
كتير حلو، أنا جاهز بلش تمرين جديد.
واو، شوف أنت تسلقت شي صعب هلأ، أنت كتير قوي.
شكرا كتير، بس كون نشيط، بس حالي أقل توتر، نام بشكل أفضل بالليل، حاسس حالي بصحة أفضل وقادر أتغلب أكتر على الصعوبات. هلأ صرت متفائل ومتحمس أكتر لأعمل أشياء أكتر.
So thank you all. Look out on the website, on the Global Health Festival website. There'll be more animations coming from the Middle East. They're illustrating health promotion in the mental health area as well as the NCD area. So thank you for your attention. Thank you again, Jawo, Sheila, and Ager, and best wishes to all those who were involved today in our conversation. Bye-bye.
Bye-bye.